Dr. Metz could start this, and then I'm going to let Jean keep sorting. Is there any type of syndrome that can cause mouth ulcers? I maybe had one. What were you thinking?
Neuroendocrine syndromes that are neuroendocrine tumors that are associated with mouth syndrome, mouth ulcers. I don't know, maybe glucagonoma. I suppose.
Yeah, that's what I was thinking. Glucagonoma will give you glossitis and a very painful tongue, but very rare.
Mouth ulcers, you need to think of inflammatory bowel disease. That would be my one thing to be. Behçet syndrome is one, but the other one would be Crohn's disease.
Another one for Dr. Metz. Is EUS advantageous in visualizing a pancreatic net that has been shown to be non-specific on the gallium-69 dotatate scan? I'm not sure.
I'm not sure what's being asked specifically, but EUS is a very useful adjunct for neuroendocrine tumors. And I think if you get a gallium that's sort of non-specific, in other words, we're not sure if this is an inflammatory lesion or if it's truly a neuroendocrine tumor, I think in that situation, EUS is actually very, very helpful. Because on EUS, you can make a couple of important distinctions. One of the most important things on EUS is to distinguish adenocarcinoma from a neuroendocrine tumor. And you can do that by the appearance at EUS as well as by putting a needle in and sampling tissue. So the far more common disease of pancreatic adenocarcinoma has a very different management and a very different outcome. And so I think if you have a gallium that's non-specific or equivocal, I would say yes, an EUS is helpful. You don't want to just test for the sake of testing. So you're only going to test if you're going to do something. And if you're not planning to put a needle in, you shouldn't do your EUS, except for MEN1 patients who we survey on EUS to see the size of the PPoma in the pancreas, because if it's over a threshold value of around about 2.5 centimeters, you would operate on those patients. So it's a very accurate tool for measuring size.
I'll start. I have a couple here. Dr. Tang, with the development of the monoclonal SST2A receptor by Jean-Claude Roiby and the availability now commercially for the same antibody to be tested, what's the status of that testing at Sloan Kettering?
Yeah, so it is a, is this work?
Yeah.
This is the specific receptor that we'll be talking about, I have been talking about for the neuroendocrine tumors.
Yeah, it is a good test for this particular tumor. However, this is, the pathology test is actually, if you will, in vitro. So you're looking at small piece of the tumor. Another way to test it is a somatostatin receptor scintigraphy or octreotide scan, which you can visualize the entire tumor. So it is part of the workup. We are trying to incorporate it into our pathology diagnosis.
Okay, thank you. Very good. Doctor.
I'm working, Odo.
Okay, I was going to have.
That's the list. We're never going to make
Good. That's all right. It'll get done. It's feasible under his watch, I think. The question is, maybe I can answer it, but I'm not sure I can. That is neurokinin A, because I think the LSU experience, Ochsner experience with neurokinin A and the finding of the elevation. My question is it related to duration of the midgut tumor? How long they've had it before it starts to change. We've seen a few change in our series and become over 50, which is the cutoff, as Jean alluded to. And I just don't know if it's a duration related to the disease or not. And Dr. Jean's not going to answer that, so I don't.
Jean is reading.
Okay. Try another one. Now you've got all the questions, Doctor, so let's see. Okay.
Richard, can I steal?
Good.
Let me start and then I'll go through a second. First question, I'll take myself. Lag time between increased pancreastatin level and detection of liver mets. I always tell people that the markers buy you about a year an early warning. Dr. Tang and Dr. Metz, would tissue samples taken for the stomach lining during an endoscopic evaluation of erosive gastritis normally be tested for METs? For NETs, excuse me, I think that's an N.
Well, it depends if the Mets is doing the biopsy or not. So the normal pathology stains that we get when we're looking in erosive gastritis are actually just standard H&E slides. They actually only look for H. pylori if we ask for it. If there's an unusual finding, then it's up to the pathologist to decide what special stains to do. But we would not take normal appearing mucosa and biopsy it. In fact, the AGA, the American Gastro Association, just put out a guideline on when to biopsy normal appearing tissues, because you can raise the cost of an endoscopy by $90 a pop just by taking a tiny little piece, because then there's pathology cost that's added on. So if you don't see any abnormality, the stomach is one area where you can ask for H. pylori if the patient has appropriate clinical presentation. Otherwise, there's no areas that we would do in a normal immunocompetent individual, but I'm sure Laura would want to comment.
Quick answers, guys. I got the Bible here. Okay, Odo, yes or no, sandostatin increases glucose? Yes or no?
Yes.
Thanks. Tattoo placed during endoscopy. Is there a potential for a burn because you have pigment in a tattoo?
No real risk identified.
What biomarkers should be used for unknown primary tumors? I'll answer that one. I do a complete set of PNETs markers and gut-based markers, and I send the tissue to biotheragnostics. Anybody send anything else?
Pathology.
Well, the pathology I already got. It's a MET, but I don't, where's the primary?
We can try.
You can try looking, okay? Dr. Tang, what's the significance does pseudoglandular have in the pathologic sense? Pseudoglandular.
In what, in tumor or in a?
I assume in a net. If you have a pseudogranular, that's all it says.
Yeah,
Okay.
it sounds like it's a pathology description of the tumor. It is not entirely specific. So as you can see, the tumor can present with a different.
Next one is important for Dr. Tang. Explain to us the difference between a well-differentiated cell and a poorly differentiated cell.
That takes 1 hour.
Yeah. I'm a surgeon, it takes me 3 seconds. It's like the difference between identical twins and fraternal twins. You got well-differentiated, you look like the cell that you came from. Poorly differentiated, you don't look. So a breast cancer looks like a breast cell. A colon cancer looks like a colon. A net looks like a net cell. That's well differentiated. If you don't know what tissue it came from, that's poorly differentiated. Is that a layman's explanation?
Yeah, it's pretty good.
Pretty good. Not bad for a fat boy. Okay, Odo, is there any type of syndrome that causes chronic mouth ulcers?
Yeah, we addressed that while you were looking, Gene, and the answer, closest one we have is glucagonoma, which gives you glossitis and a very painful tongue, but I'm not aware of chelosis, which are the cracks on the corners of the mouth.
Okay. How do you know, Dr. Tang, if a patient has a rectal net but also had a small intestinal net, can you tell whether it's a second primary or whether it's a MET from the small bowel net?
Yes, we have some clues just by routine examination, and also we can run some markers as well to tell the difference between the two. And the latest molecular testing can be helpful as well, but we may not have to go there all the way. We have some experience to tell the difference.
Okay, Dr. Tang, I'm going to pick on you again. Is there a value for doing sequential biopsies to see if the pathology on metastasis change over time?
Yes, it's controversial, but we do prefer to see the metastasis if it's been a long time. For example, if you had a small bowel primary 10 years ago or 6 years ago, and now you have liver metastasis, we would like to see that tumor to see if anything has changed, particularly the tumor grade.
Gene, I would just, if while you're looking, I asked Dr. Metz a question. Dr. Metz, when you're dealing with atrophic gastritis or pernicious anemia, and you measure very little, if any, acid, but the phenomenon of the reflux type of symptoms are going on, is that an alkaline? Does that involve pepsin or any of the other?
Yeah, so a good question, and I'll try to be quick. So the problem with reflux-like symptoms is that heartburn can be caused by lots of things, and it isn't always acid. If you don't make any acid, in theory, you don't have real heartburn, and you should not get better with a proton pump inhibitor. However, people with pernicious anemia often get dyspepsia, not so much heartburn as much as indigestion. And I think that that is associated with achlorhydria, absence of acid production, and bacterial overgrowth symptoms. So when I do have patients with PA with belly discomfort and change in bowel habits and bloating, I often will give them a short course of antibiotics, non-absorbable antibiotics.
Thank you.
Okay, can we keep on with Dr. Metz? Dr. Metz, if you have a nearly lifetime history of constipation, does that have a role in NETs?
So can neuroendocrine tumors cause constipation? I'm sure there's a hormone out there, Tom. You're going to go find it. There probably is something that's going to cause constipation.
Enteroglucagonoma per Dr. Steve Bloom, about 1979. Increasing girth was a presenting symptom in profound constipation from a large molecule that has the GLP-1. It's in the lower part of the bowel. It's called, he wrote it not once, twice, but 7 different
Can we measure enteroglucagon at ISI or somewhere?
No, you have to do maybe a glucagon assay that's a little polyclonal, a little dirty. You might be able to catch it.
You know where that would be? Where could I send a tube of blood?
You'd almost have to check, and they're all polyclonal for glucagon, but some of them are a little broader. I can't be sure.
Okay.
Well, let me just tell you one thing of importance. Constipation in a neuroendocrine patient, think of MEN1, hyperparathyroidism.
Yes.
That's a good point.
Very good
Okay, this one's for me. Can the results of the studies on pancreastatin and neurokinin A regarding small bowel and duodenum and PNETs be applied to other things like lung nets? The answer so far in our experience, no. If you came as a mid-gut net and you had an MVOT, a multivisceral organ transplant, where they took out your stomach, your liver, your pancreas, your small bowel, etc., could you still be considered having a mid-gut primary? Yeah, it's where it came from, and that's what the best markers to follow: pancreastatin, neurokinin, serotonin, plasma 5-HIA. Dr. Warner, what role does stress play in the development of NETs? Is there information displayed on slides at the conference available for access after the conference? You need to ask Bob and Marianne. It's my understanding that we're going to have some of the talks recorded. They're being recorded. They're going to get edited and put on YouTube. Back to Dr. Warner.
There is no evidence that stress induces NETs, although, as I said, it can provoke a carcinoid syndrome or even a carcinoid crisis by stimulating the internal or endogenous release of adrenaline epinephrine, which is provocative.
Dr. Warner, Dr. Metz, took octreotide and lanreotide, ended up with gallstones. Hello, 40% of people. What to do for stones created after you've had your gallbladder out? What if you end up with common duct stones or stones in your pancreas or something like that? What do you do?
Dick?
Well, first of all, many of us administer ursodeoxycholic acid, a prepared drug. It's a bile acid which solubilizes bile and helps to deter crystallization into stones. And I don't know of any formal study to confirm this as a practice that should be done in all patients, but I do it, and it seems to be effective.
It's more, does it keep them from forming, or does it help dissolve when they're formed?
I have not seen it help to dissolve existing stones, but it seems to deter or prevent development of new ones, which is very common in long-term treatment with octreotide or lanreotide.
And it's important to know and remember that the other action of somatostatin and the congeners is the profound flaccidity. We heard about the hypomotility of the bowel. The same thing happens to the gallbladder. It gets very flaccid during a time when it's supposed to contract. So you have that against the stasis of the gall juice before it gets out. So it has that action to lead to the stone formation, sludge.
I'm going to read this because it pisses me off, pardon my friends. Anyone who can be, that's addressed to anyone who can be objective and truly cares about improving NET's patient care. So anybody here care about patients? Just in case there might be somebody. How is it that there's no mention of new biomarkers? This is the REN test. And is this a fair and balanced representation of what exists, or just a representation of who has been paid to play? Very concerning. I came to learn about what's new, like gallium, PET, and PRRT. Will you please address the graph? I will tell you my experience with the REN test. And then we'll go through, and I hate to be negative, but I have a patient who is a physician and her sister. They both had the REN test. The sister, who was normal, had a positive REN test. The sister who had widespread metastatic disease had a negative REN test. They thought they got them mixed up. They redid it, and it was the same. I have not learned, and I have a number of patients who've done REN tests without me recommending it. They just did it, and they came and brought it to me. And again, one of the problems with the REN test is that if it indicates that you have growing disease, by and large, you're asked to go back to your family doc, who may or may not have any clue what molecular profiling is. I can only tell you that I'm vastly offended if you think that I'm here because I get paid to play. I get $1,000 and I've spent the last 2 years. And I would get that from NCAN, not from a drug company. So the fact that I don't happen to think the REN test is a valuable tool in my practice at this time, with my level of understanding, sort of hunks me off. Okay, please, other guys, I know some of you must care about your patients.
Well, so difficult to respond. A lot of underlying comments in that, reading between the lines in the question. Let me say that tumor markers are important in this disease in general. We need to identify predictive tumor markers. So then, in other words, you don't want to just be able to get a chromogram and it's going to say, yeah, this is or isn't associated with a neuroendocrine tumor. You want to know that this marker is going to be able to tell you how Mr. Jones is going to be doing in the future. It's a predictive biomarker. You've heard about predictive biomarkers. Some people are very in favor of certain markers. Some people are very in favor of other markers. I think this is an area that is a growing area of great interest for us in the neuroendocrine world, both from the patient and the therapeutic physician perspective. This particular test, we are actually in the process of evaluating at the University of Pennsylvania. We have an ongoing trial, which I think is going to give us some useful information. This is all stuff we are learning. I'm not ready to throw a test out, and I'm not ready to put a test in until I can, in my own practice, get a feel of how I'm going to use it clinically. Yeah. And so I don't think that any one test is better, worse, or more predictive than any other one right now, because we are learning with this particular test. Yeah. The theory behind the NET test, I think, is sound, and stay tuned. Hopefully next year this time we'll have some data.
Yeah. Odo?
Yeah. No, I concur with David's comment, especially how to use it, because I keep feeling that its usefulness may not be in a regular monthly type of monitoring, or hopefully never monthly, but every 3-month monitoring. And so there probably is a role for it. I think an issue that Dr. Su and I discussed regarding it is the more information regarding and alluded to by Gene, was the false positives. What do you do with a false positive, or what's the % of false positives? I think that's what Gene's point was. And I think that kind of information needs to be brought, it has to be further characterized, as David said. So we see quite a few come through as well in our clinics. And
Dr. Tang, you have any comments?
Yeah, I think it's well said. There are a lot of evolving tests which needs to be validated in the process. The ideas are all great, but we, as you already said, we need to wait a little bit longer.
Richard?
The concept behind the REN test is good, but the test itself has not been proven even close to being dependable for clinical application for actual use in cases. It needs further proof and for further development.
You being paid by pharma?
Unpaid.
Unpaid by pharma. You know, guys, I got to tell you, I'm really offended. I'm really offended. Let me say the pros of this. It is the emerging technology of the future. It's not necessarily here yet, but I just got back from the AJCC meeting, and for the first time in history, with breast cancer, they're going to put molecular profiling in as part of the staging procedure for breast cancer. It's coming. I don't think it's here yet. It doesn't help me it raises more questions than it does answers to the questions. You know, but the implication that I take money from major pharma to put on this conference pisses me off.
That's right.
Dr. Waldering, since gallium-68s are revealing bone mets in many of us, what's the best approach for these findings? For us, what we do with bone mets, and it's an interesting experience that we've had, we really don't have progressive disease. We use Zometa as a once-a-month infusion. We have vitamin C, vitamin D, and calcium. We don't use Xgeva. It's a monoclonal antibody. It works in a different way, and I don't think it's nearly as effective at controlling bone mets. Is there a guideline? In our clinic, it's sort of just knee-jerk. I mean, and it's a good question to ask Richard Campo when he's up here in the next session about bone met progression if you put them on Zometa, vitamin C, vitamin D, and calcium. In our hands, it's highly effective. Oh, this is a good question I'm going to ask everybody here because I think it's going to be a problem in the future. Why get an Octria scan as surveillance? Why don't I just go ahead and get a gallium-68 scan? And I think at least part of the answer, and I asked Dr. Wallen, and Dr. Wallen said they put at one of their PET scanners doing nothing but gallium-68 for that whole PET scanner all day, every day, all week, etc. For us, we don't have the capacity to do switch everybody from Octria scan to gallium scan. Odo, can you do all the people you now get Octria scans on?
No, we're still, two things. We're still on what they call a IND, an investigator new drug, which is FDA approved for protocols. So these are all clinical trial type of things. We now know the gallium-68 dotatate has been approved in a shake and bake form. And that's going to be widely distributed. It's already been approved. It probably won't insurances will catch up with it, they estimate, in another month or two. But that's going to still be a technical problem, and I think it alludes to there are 4 or 5 good centers that have them now, but in terms of accessibility, it's going to come in very slow. Just like if you go back to '94, Octria scan was very slow to come into the smaller hospitals because of, and that was a kit form. The gallium-68, as we understand it, kit isn't really totally a kit because you need some startup costs from each nuclear medicine place. So I think it's going to still be slow coming in. Not only that, but with the Lutathera being accepted, it's predicated on the Octria scan. So, and the Octria scan is handy. It still has value if you use the Craning scale correctly to read against the liver at 24 hours. So I think there will be a use of Octria scan as you go forward once Lutathera comes out.
Okay, Otto, one more thing I'm going to throw at you. Gallium-68, this patient's tumor only showed up on an F18 DOPA scan. Where do you put that in with gallium, Octria scan, MIBG scan, et cetera? Where's the F-DOPA scan fit in?
Well, I think the F-DOPA, we don't have it here. Wisconsin does. I know they use it at the NIH. I think it's particularly helpful in pheochromocytomas and paraganglioneuromas. And I've seen the pictures where there's sometimes the gallium dotatate doesn't catch it. I'm not sure. I think the only time it's helpful in carcinoids or midguts is when serotonin, and that's from a paper that came out of Europe about 5 years ago. If serotonin levels are very high, dopamine, or the L-DOPA, F18 DOPA will detect tumors. But I don't, my experience isn't broad at all. Maybe David has it, or Richard may have some comments.
Jesus. Okay, when should I worry about my serotonin levels affecting my heart? In the high hundreds, thousands? We use 1,000. The Queen of Hearts is going to be here. Heidi Conley. She knows more about serotonin and carcinoid heart disease than everybody in this room put together. I mean, we sent 8 people last year to get their valves replaced, and we don't have the capability of having a multidisciplinary team for heart surgery, and we send them to Mayo. I can only tell you that's, if I had carcinoid heart disease, I would go to Mayo and have Heidi's team and ask her the question, but I think the magic number at a bad serotonin is about 1,000.
I'll have to differ with you on that.
Please do. I'm here because of Big Pharma.
At Mount Sinai, we have a heart center, and we see and operate a fair number of these patients. There seems to be no discrete value above which carcinoid heart valve disease will occur with blood serotonin levels.
How often do you echocardiogram these people?
every new case gets an echocardiogram, and if they have elevated serotonin levels at all, they should be echoed once every year.
That's what I do. I do echo on everybody once a year, period, no matter what, and then we're trying to put together how that's going to correlate with serotonin.
And just in support of that, Kaplan, when they reported their series from the Royal London, noted that it was the time of carcinoid, the duration is independent. You can be a short period of time to develop it, or a longer period of time, and that kind of surprised me. So the serotonin levels, I think, can be a little deceptive. Actually, all the good data is on 5-HIA, I think, as we go forward.
Dr. Metz, I hear that many of us on sandostatin monthly injections can have severe gallbladder attacks, severe kidney stones, treatment shots, Y90. I know about octreotide and gallstones. Does it give you kidney stones too?
I don't believe there's an association between somatostatin analogs and the development of renal stones.
This is for me. How long do you have to be off PPIs before markers will show increases or show normalization? May take up to 6 months.
Is that
Odo, here we go. If my scans are clear and blood work is normal post bowel and liver resection, should I be taking lanreotide injections, or will I become immune to its effects and cause it to be ineffective over time?
So,
i.e. tachyphylaxis, and the question is, if you've had all your tumor resected, do you need to be on prophylaxis against tumor regrowth?
it's a great question.
That
and
is a great question.
Yeah, and I want the other folks to talk too, but Dr. Howe and I have working through our patients on a regular basis, come to find out after a year or two on revisits that the markers, especially for us, serotonin and pancreastatin, are staying very normal after he had changed their biochemistry. And we're giving them holidays. I mean, I think for just the reasons that were brought up, I think you can, until you have first evidence of CT evidence of a lymph node that wasn't there before, or something in the liver that looks suspicious, you can restart it. How do you do it, Richard?
I have to agree with you.
I got a question for Richard. Richard's wife, Monica, who passed away several years ago, was the queen of nutrition. And so I'm going to sort of have you morph into Monica for a minute. Okay? Has anybody you know been diagnosed with a neuroendocrine cancer of the gut and survived, but has not opted for surgery? Can proper nutrition, exercise, and care, can the body heal itself from a net? And the difference between lanreotide and octreotide, we'll get to that as a second question. Do you think nutrition can cure somebody, or is it used as an adjunct to conventional therapy?
I don't think it can be curative. I think it's an adjunct to conventional therapy.
And that's from the guy who lived with the queen of nutrition. Okay, Odo or Dr. Metz, difference between lanreotide and octreotide? Is there a difference? Are they identical twins? Are they fraternal twins? What are they?
I suppose they're closer to well differentiated in my mind. I think there's a couple of points. There are people who want to switch from A to B or B to A. I'm always wary of switching somebody who's doing well on the drug because I don't know necessarily that it's going to do better on the other one. In my own heart of hearts, I think they bind the same way, work the same way, and at their therapeutic doses, I think are very similarly effective. Yeah. There are personal choices that people make, but in my own mind, I think as a class, these drugs are very similar.
Yeah. We're going to hear, I think, more from Dr. Liu later on in the meeting, but I would just say I agree completely with David. There is the absorption's identical between the two, namely about 68%. One's a square wave when it gives you an even level all the way through, whereas octreotide LAR has a peak and a trough. We'll probably hear about that. And we have had instances where people cannot tolerate the LAR and have been able to tolerate the non-vehicle carrying lanreotide. One thing that's happening, though, I think, and we're seeing it, is that medical oncology are very driven for FDA-approved drugs, and for anti-proliferation, which David alluded to, the lanreotide has a clear indication for that. ProMed did the same thing, but it didn't get indication from the FDA. So many times we see patients coming in already on lanreotide. We say, okay, that's...
Odo, what do you do with the person who is bradycardic on octreotide or lanreotide? I see it rarely, but it really does exist.
It does, and I think the one thing, and I did, the very first time this happened was a long time ago with sub-Q, and my colleague was talking to me about it, and in this case, the patient was profoundly hypothyroid, so the answer was easy. We just gave him back thyroid, and that's something I think you ought to think about to make sure it's not, because thyroid has a large effect, as you all know, on slowing on speeding up the heart. So you need all three function tests.
Free T3, free T4, and TSH.
Yep.
Okay,
Yes.
Dr. Tang, you said something that piqued my interest, and that was you implied that if you stained a tumor for VIP and it was positive, that would reflect VIP in the plasma and causing symptoms. Do you believe that in your heart of hearts? Or is it plasma that is the gold standard, or a stain of the tumor that's the gold standard?
I think both are clues for the diagnosis. And I said, the
But if you had a VIP stain that was very intensely positive and negative plasma and diarrhea, would you attribute it to being VIP?
I would challenge the test being repeated because
Okay.
these tumors oftentimes they do release what they make. So
Odo, you did extraction of 1 million tumors. 1 million. Odo's elixir is still the elixir of the gods.
Ages.
You take the tumor tissue and you put this acid alcohol, and it draws all the peptides out of the tumor, and he can then measure it in radioimmunoassays like they did at ISI. And Odo did all that work. That's where we know about all this stuff. Anyhow, what do you think about which is the gold standard, the plasma or the pathology stain?
And I think the case that Dr. Jean was talking about was, and there's been articles about tumors with multiple peptide, multiple peptide staining. And I think the thing that wins is the hormone in the blood and the syndrome, or the symptoms in the case of insulin. So I favor, and I think, and Dr. Howe's here, he may want to comment, but he did PPomas, and true PPomas with high PP levels in the blood, and the stain was uneven in the tumors. So I think the blood wins if the syndrome is there and the levels are high enough.
Okay, this one is for Dr. Warner. The DNA toxins, radiotherapy, how do they affect normal cells? Are they capable? I've never even heard of them, so you're going to have to explain to me. Are they capable of causing other mutations in normal cells in addition to clogging the wheels of neuroendocrine tumors? I got to tell you, you got me by the short and curlies.
If I understand it correctly, the question is asking if modalities which are toxic to DNA, which destroy or alter the deoxynucleic acid, if they affect normal cells. Yes, that's why we get side effects of some nature. For example, losing hair in response to certain drugs. The hair cells are damaged, and they can't make hair as well. The faster a cell is growing, however, the more vulnerable it is to the effect of these agents, and therefore it works mostly on more rapidly growing cells of cancer than it does on the normal cells, but it does work harmfully on the normal cells. That limits its use.
Dr. Metz, can psoriasis masquerade as a neuroendocrine tumor of the skin?
I think a good dermatologist can distinguish migratory necrolytic erythema, which is the name for that rash, from the other rashes. And important to realize
Or
that...
Merkel's?
well, Merkel's being a totally separate disease. That's a
Yeah.
neuroendocrine tumor of the skin.
Right.
So I think, a good dermatologist makes that distinction. Let me just say...
And a biopsy is diagnostic for sure.
Correct.
Absolutely.
You have to do a biopsy. Now, one of the important points is there are other causes of MNE. So if you get an unusual rash and you think you might have a neuroendocrine tumor, as Dr. Waltering just says, make sure you get a biopsy of it. A good pathologist can tell you what they're looking at. But MNE, migratory necrolytic erythema, is not only seen in glucogonoma syndrome, and it is seen in cirrhosis and chronic liver disease as well. So you need to make sure that that is not an underlying cause.
Okay, I'll answer this one. Why does it take so long for to get blood tests from ISI? The answer is multifaceted. One, you got to get it drawn at LabCorp. They have to process it at your local lab. It goes to a central lab. It gets processed again. It gets shipped to ISI. ISI gets in an order. Recently, the 5-HIA plasma machine, which is a very expensive doodad, broke down. They had to buy a new one. They had to program it. They had to get it up to speed. I think they're back to normal again. I tell my patients, get your blood drawn a month ahead of seeing me, and you'll have no problems at all. The next question is, best management for neuroendocrine carcinoma. Dr. Odo, you want to talk about neuroendocrine carcinomas, the undifferentiated tumors. In our group, we send those to Rob Ramirez, our medical oncologist. Yeah. Those are the chemotherapy type things. What about the rest of you for the undifferentiated tumors, not the well-differentiated?
Yeah, I just want to make sure. So it's the poorly differentiated neuroendocrine. That's the group we're talking about. Carcinomas.
The bad boo-boos,
so,
KI6750.
So our pathologist, and that's why I alluded to the SST2, has finished a large different classification, SST2, and it's important to note that up to 35 to 40% of those may have receptors, and that indeed does change how we proceed. But for the most part, we do what Gene does. And we'll actually, in that regard, if they have the receptors, we'll go ahead and do a gallium scan to see if there's a potential for a PRRT form, but and an FDG PET. But we work with medical oncology very closely on that. Sometimes adding octreotide if they have the receptors, or doing the functional gallium to make sure to see if they have receptors. Sometimes there's an uncoupling.
All right, in that same line, Dr. Tang, what is the difference between a well-differentiated grade 1 and a well-differentiated grade 2 tumor? If the focus is on well versus poor, what does grade 1, low proliferative index, versus grade 2, intermediate proliferative index, tell us in well-differentiated nets?
So I think I presented some of the information in my talk. Within the well-differentiated, you can have different grades. Now the new WHO is going to add G3 as well as G1, G2. Yeah. So within that category, you can have different grades. But from our current knowledge, we don't see a huge difference in genetics. So it's just the tumor is growing faster when you have a higher grade. But not necessarily having a new mutation or new target.
One of the most common questions, Laura, that I get asked every week at least a dozen times. is, can your Ki-67 change over time? And is there a difference between the Ki-67 of your primary tumor, your lymph node, and your liver met?
Yes, it could change over time, particularly with this disease. The interval is very long. Not only the tumor is changing, your body is also changing. So yes, with regard to primary versus metastasis, we turn to think that metastasis would have a higher proliferative rate, but it's not necessarily true. You can have either way. Sometimes you can have a higher grade at the primary site and lower grade at the metastasis. So we have seen it both ways.
Yeah.
Okay, this is for Dr. Odo, Metz, Warner, and Woldering. Do you use chromogranin A still? When do we get rid of chromogranin A? Shoot it in the head and hang it. Dr. Odo, do you still use chromogranin?
Yes, I do. I do.
Is it time to shoot it in the head?
You know, when you look at it, and I agree, by itself, it's everything that's been said about it. But I think if you look at it in a continuum of the same patient, in a periodic basis, in the same lab, you start to develop profiles. It's 3 peptides for the midguts that confirm or tell a story, or it's a helpful emphasis on where you think you're going when you
And
put
if the
CT.
patient's on proton pump inhibitors, do you still?
No, I think that's the most difficult, because my notes say it confounds the interpretation of
Dr. Metz?
Before you guys all jump at me, I use
Me jump at you?
I
I'm paid by Big Pharma.
with the proviso that tumor markers are not predictive, I think I would say the one marker that I use most is chromogranin A.
Yeah.
I use it to distinguish between neuroendocrine tumors and other tumors, where I think it has been shown to be useful.
Yeah.
I think the trend with time, all other things being stable, is reasonable to follow. But having said that, I tell my patients, I treat the patient, I don't treat tumor marker levels.
Yeah.
Okay. Dr. Tang, 3 institutions have graded my primary as 2%, 11.63%, and 4.5%. Help.
Yeah.
I didn't-
This patient apparently had a primary taken out,
Right.
and it was sent for 3 different pathology labs
different labs.
for evaluation. Ki-67 at 2%, 11.63%, and 4.5%. Do we need 5 more as tiebreakers? Do we need one Laura Tang, David Klimstra to look at this and tell me which of these are reality? Or was this just a sampling error? Was this really different, 3 different spots in one primary?
Yes, so yeah, it's a very interesting. I think we have to put things in perspective. Everything is relative, particularly come to pathology. For example, if I have a tumor for, say, 10 centimeter, we're not going to look at every single cell of that tumor. Even we submitted all the tumor, as you see, when you put a little piece of tumor in a paraffin, but when we shave the slices, it's only 4 microns. So that's 0.1% of that piece we put in the paraffin. So it's not representing the entire tumor. So there is heterogeneity within the tumor. Whenever we have a bigger section, we look at many different sections. We choose the ones we think is the highest grade, and then we grade based on that. So, but if I have a small biopsy, it may or may not represent the true grade. But I would say within 1 to 5% probably doesn't make a huge difference. When it goes higher to the 10% range, one may consider another type of evaluation.
Dr. Metz, what's the next step in diagnosis if a patient has symptoms, severe was through, I'm editorializing, of carcinoid, but negative tumor markers? What do you do next?
So that's actually the protocol I was alluding to earlier that we are doing right now, looking at the Ren Labs NET test. I think that's where it may potentially be a useful test. So we have a protocol in patients who appear to have the carcinoid syndrome but no evidence of disease. And we are in a blinded fashion looking at NET test presentation, and 6 months later we're repeating chromogranin A, 24-hour urine, serotonin, and the NET test at 6-month intervals. I've been asked many times, do I think that you can get the carcinoid syndrome without a tumor? Just like we can in other neuroendocrine tumors, get a tiny, tiny little tumor. I think it's extremely unlikely, but I don't think we'll ever answer that question. So I think the point is that there may be something out there that gives a syndrome-like presentation without tumor. You need to think of other diseases. Mastocytosis is an example of one condition that can masquerade like this. But my bias is if you're going to have the carcinoid syndrome, you should have a neuroendocrine tumor.
Okay, Dr. Metz, what's the best way to treat B12 deficiency, gastric carcinoids type 1, 2, 3? Are these midgut carcinoids, or are these just gastric carcinoids for type 1, 2, 3?
Right, so
and the question about the best way to treat B12 deficiency.
Right, so the type 1, 2, 3 carcinoids is a classification for gastric carcinoids. There are those that feel there's a type 4, which we can talk about, but I don't think there's enough data yet to support that one way or another. Type 1 and 2 are ECL cells. Type 3 is another cell type, controversial as to where it comes from. If you have type 1 gastric carcinoids, that's a consequence of gastric atrophy, often with intestinal metaplasia. The risk there is gastric adenocarcinoma in addition to carcinoids, so they need to be surveyed. The B12 deficiency is an
Surveyed how often while you're teaching us?
Well, so my own
Once a year?
My own personal bias is to survey every 3 years.
Okay.
There are those that feel if you have widespread atrophic metaplastic antral gastropathy affecting the fundus and the body, and there's lots of inflammation and it's multifocal, that it should be done every year. The guidelines in the US do not exist. The guidelines in Europe vary between 1 and 3 years. It's an expensive thing to do. As far as treating the B12 deficiency, I think that is the biggest risk. If you don't jump on B12 deficiency, you can get significant morbidity associated with it, and so it should be replaced. I am still old-fashioned and favor subcutaneous B12 once a month. I think nasal administration has been shown to be effective. I don't think oral B12 is very, very useful. It doesn't really matter how you replace your B12 as long as you measure your B12 and show that B12, when replaced, is in the normal range.
Next one's going to be Dr. Warner, and the question was type 1, type 2, type 3 gastric carcinoid. Does it progress from type 1 to type 2 to type 3? It's not staging, guys. It's not grading. These are totally different kettles of fish, in my opinion. What do you think, Richard?
I think that very rarely a type 1 or 2 can wind up changing to a type 3. I've seen it, but it's very uncommon.
Listen to the man.
It's very uncommon and makes you wonder if the sampling was correct to begin with. The clinical course is also to be considered, because if it's a type 3, it usually goes much faster, and the clinical features will be in a shorter...
Speak into the microphone.
The clinical features will indicate that the tumor is more aggressive from the start if it's a type 3.
Okay.
Can I comment on that?
Yeah, please.
So,
You taught me something. I would have bet you the deed to the house that a type 1 and a type 2 wouldn't become a type 3. But I learned something.
So
That's why you're here.
I think the point Dr. Warner is making, I just want to make a slight difference in the presentation of that. Type 1 carcinoids, generally speaking, benign behavior. Type 2 carcinoids, sort of intermediate behavior. Type 3 carcinoids, more of a concerning behavior. On occasion, and I would agree, we have seen type 1 carcinoids that can be aggressive. We're actually busy writing up a couple of those patients. But I don't think they morph as much as their behavior alters. Is that a fair interpretation, Dick?
One more question for Dr. Warner. and it fits in so beautifully, I can't believe it. It's like somebody paid me to do this. Can a non-functional tumor become functional, and can a functional tumor become non-functional?
That's a great question.
Let me add my personal note for Odo. Can you go from an insulinoma to a vipoma to a pheochromocytoma and back to a glucagonoma over 40 years? Well, let Richard start.
Yeah,
I'll answer the question first that you asked Odo. A tumor can change its production of peptide with the passage of time, maybe not to a wide variety of such agents, but it's very well recognized that a tumor that was making just serotonin can wind up making something else after a number of years.
I've seen gastrinomas start making ACTH very commonly. Those are very bad tumors. Odo, can you tell the story of what's her name? Helen Turner? The lady who Dr. Zollinger had, who morphed from a gastronoma to an insulinoma.
Yeah. Well, and then it's actually yes, and she went to a somatostatin, actually co-secreted somatostatin with her gastronoma, and it was that was the first patient that Zollinger did surgery on. It was a multiple endocrine neoplasia patient. She was 17 years old at the time. He had taken her stomach out when she was 17, and her gastrin levels remained very high, and we could never quite figure out what was going on, and finally we did somatostatin and went back and looked at her tumor. She was making somatostatin in the tumor as well. So she co-secreted. Gene and I have worked on a VIP secreting tumor that was co-secreting. But you can they can toggle. I mean, a very prominent case, a person passed away recently, started out with an insulinoma and then became a glucagonoma. And that's how he passed with the glucagonoma. So they're known to be able to do it. But here what you're talking about, for the most part, you're talking about pancreatic neuroendocrine tumors, less so with the midguts as far as I know, and foreguts. So these are the functional, the 3 out of 10 functional tumors. You always need to worry about them. In terms of non-functional becoming functional, I think we have seen 2 cases where everything was non-functional by measurement and by symptoms, everything was clean, and one went to a predominant gastrin-secreting tumor, and the other was, we think, was an insulin-secreting tumor. So, but it's not uncommon to see clinically and biochemically the combination.
Again, I'll expand on that question about non-functioning, net becoming functioning. It's not unusual if a tumor has a low-grade function and then over a period of time grows larger and spreads, so there's a bigger volume of tumor, therefore there are more cells available to make the hormone, and so the tumor may end up, when there's a great deal of tumor, to cause a clinical syndrome.
Okay. Let's see. Dr. Metz, can carcinoid syndrome cause a rash on my neck?
Well, I suppose that would be a setup for pellagra, which is certainly a nice deficiency.
Other than just winging it and saying, ooh, that could be pellagra,
Right.
How do you prove somebody has pellagra? Can you measure something?
You can measure niacin.
Where?
Well, I just had one done actually in the last week and came back with a normal result, and I was going to predict it had to be abnormal because this patient had a big rash. Classic, looked like pellagra.
Where did you get niacin
I don't
measured?
know where it was sent to. It was sent through our lab. I can find that out.
Well, so if you need a niacin, go to Dr. Metz.
No, I'm not saying we got it right, because the result was surprising to me. I was expecting my first positive in, I think, as long as I can remember. But yes, pellagra is
Richard
associated.
is the king of niacin and pellagra. And you work with a Canadian gentleman who I remember is one of the top niacin measurers in the world. How do you get niacin measured?
First of all, you can get niacin measured, but it's easier to measure tryptophan, the essential amino acid from which it derives.
Yeah.
If niacin is deficient, in this instance, tryptophan will be low because that's where it comes from.
And where do you get tryptophan levels?
That's an amino acid, and you can get blood levels of various amino acids determined
Just through
by
Quest,
by
LabCorp?
most laboratories.
Most laboratories, okay. Learn something else, okay. Dr. Metz, is EUS advantageous in visualizing a pancreatic net that has been shown to be non-specific on gallium-68? I got to tell you, the one thing that bothers me about gallium-68 that I've been faked out of my jockey shorts a few times is that the head of the pancreas on gallium-68 scans are falsely positive.
Yeah.
And I do EUSs and I don't find anything.
Yeah.
Do you find the same thing with yours, Odo, and Dr. Metz and
yes,
Dr. Warner?
and there's a paper recently that shows that there's a concentration of they talked about the PP cell, and probably the pancreatic polypeptide cell is so avid for receptors, it'll give you a false positive. And that's a really important point because the surgery required for that can be a very extensive surgery versus another part of the pancreas. So we do ultrasound like Gene does. And yes, we have seen the galliums with that. They almost become
I had a patient who came to me, I said, this is non-specific, and she went and had the head of her pancreas removed elsewhere, and it was a big fat nothing. So, I mean, you know, that's a big operation for a big fat nothing. When you start doing gallium-68 scans, you got to talk to the people like Odo and Eric Liu, who've done a lot of these scans to understand, because you're a novice and they're the experts. And some of these scans can give you strange abnormalities. Okay, one for me is taking protonics or GERD medicine long-term cause growth of carcinoid tumors in midgut. Very controversial. There's a guy named Courtney Townsend who is chairman of the Department of Surgery at the UT Galveston, and Courtney has written many papers about gastrin being trophic for other kinds of tumors. And we wean all of our people off of proton pump inhibitors onto H2 blockers. It takes a long time. It may take 3 or 4 months to do that. We have a sheet that you can call Summer in my office, and she'll send you the sheet. It tells you how to wean off of PPIs onto H2 blockers.
Can I comment on that?
Please.
Very, very controversial side effects of PPIs, very hot in the press. The New York Times has articles all the time. Every week there's another paper coming out about how PPIs are bad for you. They're not. They're good for you. I'm not suggesting you should put it in the water, but there are certain indications for long-term PPIs, and I don't want to hit those long-term indications.
Everybody agrees on Barrett's. What are the other two?
So the three causes for maintenance PPIs: reflux disease that is symptomatic when you try and get off them. Lowest effective maintenance dose, if you have Barrett, should be at least once a day. Hypersecretory conditions, Zollinger-Ellison syndrome, H2 antagonists don't cut the mustard. They're rare, but that's the second cause. And probably the biggest indication for long-term PPIs, in which many people are stopping their PPIs and getting upper GI bleeding, is non-steroidal prophylaxis. So even if you take an 81 milligram dose of aspirin once a day, you have a 2.2 times increased odds ratio for a life-threatening upper GI bleed. And I can tell you in my practice, I see many patients walking in the door who tell me they read an article in the New York Times about Alzheimer's, about kidney disease, about bacterial overgrowth, about pneumonia, about all the other putative side effects which do exist. Stop their drug and I'm now got a life-threatening bleed or my heartburn's killing me. So these drugs,
Now,
like any other drug...
Do they transition slowly to H2 blockers? The one thing you can't do is stop a PPI. Because your gastrin is sky high, and so you've got 6 gallons of gasoline on the fire, and you just can't do that. You must slowly transition.
So H2 antagonists are not effective prophylaxis for non-steroidal gastropathy. Been many papers on that. The standard dose for NSAID gastropathy prophylaxis is a half dose PPI once a day in the morning before breakfast. Having said that, there are many people in the world who are taking PPIs who do not have any of those 3 cast iron indications, and in all of those situations, you should use the lowest effective maintenance dose and try and wean to off completely, as you are doing. But the reason I'm commenting here is there are too many people out there, read the New York Times, stop their PPIs, and end up at risk. So should be done carefully.
Listen carefully to what Dr. Metz said. You can't stop your PPIs. You got to really have a plan if you're going to try to get off of PPIs. Go, and it takes a long, long time. Richard, do you agree with that?
I do. I do agree with you.
Dr. Odo, I've had 2 Y90 treatments on the liver 2 times. I assume they're talking about radiospheres, like Surspheres, Theraspheres. How long do I have to wait to see if I may have PRRT, or can I have this at all? Very good question. I wish Dr. Nutting from Denver was here to talk about RAID, which is radiation-induced liver failure.
Yeah.
Odo, what is...
So the one paper that I'm aware of is from Germany.
Oh, they say it doesn't matter.
They say yes, but there are 2 things to recall. Right now, the dose of Y90 spheres, the amount of yttrium you give when you do it hepatically, is 4 times the amount that's delivered peripherally for PRRT. The issue that Gene alludes to is the radiation damage, ionizing radiation to the liver with the beads. And that's becoming becoming more prominent as time goes on, because ionizing radiation gives for a long, long time.
It's the gift that keeps on giving. It's like herpes.
Yep.
Once you got it, you can't get rid of it. You can't unirradiate somebody.
Yeah, but the Europeans, that one paper was pretty well done, and it says they're not mutually exclusive, and you can do either in either
I think
order.
we killed 5 people, or maybe 6,
And that has-
where we gave them at least 2 rounds, sometimes a 3rd round of spheres, radioactive yttrium-90 containing spheres, and we happen to use Theraspheres, not Surspheres. And then we sent them to Europe, thinking that Europe was going to do dosimetry. In the meantime, Europe had said, hey, we've done so many of these, we've done 3,000 of them,
Yeah.
we're not going to do dosimetry anymore. And really slipped us a Mickey, as it were, in the fact that now these patients had a lot of radiation through the liver for Surspheres, or Theraspheres. And what you got to remember is they do distribution, they don't do dosimetry of the beads. And so we don't know what the normal liver got. And now you send somebody to Europe and they don't do dosimetry anymore, so you don't know what the normal liver got from PRT. Now you're flying blind, and those people present with like cirrhosis and ascites, and then they develop liver failure, and I got to tell you, they die like a poisoned dog.
Well, it just, the other thing to remember is the amount of tumor burden. And so we're trying not to do that sort of thing, or even embolization prior to PRRT. And that's 2 centers now that are practicing that in Europe. Basel and Bad Berka both are recommending holding everything until you have PRRT, with the idea that the vascular anatomy is completely intact when you don't perturbate them. And it makes sense, but it's very difficult in a situation where you're trying to arrange that type of therapy, and you folks are having issues.
So tell me what you do, Odo. Do you use spheres and PRRT together, Or do you
we've got-
use chemoembolization and PRRT, which is what we do?
So we use chemoembolization when we need to do it, bland embolization and PRRT.
But what about spheres, radioactive spheres and PRRT?
We don't have enough, we haven't done it in a formal enough way to say. We have probably done that in the past.
Okay.
We've done spheres, radioactivity and then sent for PRRT. But I know we've not had any that I'm aware of complications.
Dr. Metz, you had a slide that showed a rash on different parts of the body. Please repeat what it was. Was it a glucagonoma?
Yeah, so that was the glucagonoma. Migratory necrolytic erythema usually occurs in areas of stress and tension on skin. So it's in the groin, it's under arms. And it often heals with ulcers, with blisters that heal and they get pigmented. So there's a classic presentation to MNE.
This is a good one for sort of everybody up here. When do you intervene when you have liver mets? I have a liver met, I have multiple liver mets that are growing a half a millimeter every 6 months. Should I leave these alone? What intervention should I have? And they didn't tell me how many they have, or are they on one lobe or whatever, but I'm going to assume that they're everywhere, What is the intervention? And do you base, and this is especially for Odo, who's the king of liver loads, it on the amount of liver loading? Do you do somebody with 60% liver load different than 30% liver load, et cetera?
Yeah,
Start with Odo.
Well, first thing I do is work with Dr. Howe, who will be talking this afternoon too about reductive liver sparing reduction surgery, because we really do that. We'll sometimes reduce the larger tumors and leave the smaller ones, and that's a group that we tend to do prior to sending over for PRRT, where we just have the direct intervention to the larger tumors. And so we do liver sparing surgery on the larger ones. I don't know that number. I know if there's probably, Jim can answer, 3 or 4 larger ones. He'll go after those with RFA usually, and leave smaller ones. And we can.
Then do you do PRRT at that point, or do you do
ideally we would follow
chemoembo, or what do you do?
No, we would follow it up with PRRT, knowing if their gallium showed those lesions before we.
Dr. Metz, what do you do? What is your liver met protocol?
Right. So I would stress that this is a multidisciplinary disease, and tumor board is where you will discuss these issues. Everybody's hammer looks like their own special kind of nail. My approach is to debulk tumors as much as possible up front. I'm in favor of surgery early if doable. We use a lot of liver-directed therapies. There is synergy between the radioactivity of surgeries and PRRT, which we're concerned about. I think the first approach is if things are stable and not growing, you sit tight. I think that's reasonable. I like sitting tight on a somatostatin analog, although that's controversial. And beyond that, I think all bets are off as to which is really the right way to manage these people. Our interventional radiologists are very wary in people that have a tremendous liver bulk. So if there's a lot of tumor, you're at risk of liver failure. And we would stage the treatments if we're going to do them at all. On occasions, we even embolize the vein on one side of the liver to grow up other parts, and then do it in a staged manner. Very little tumor burden. I think it's totally appropriate to wait, because you don't want to fire all your bullets at one time, as Mike Sulin likes to say.
Exactly.
So I really think the important point is this is a difficult question. It's nothing we can answer in a quick little chat here. It requires multiple experts around a table looking at the patient, knowing the chronology of disease, following the patient with time, and realizing this is a multimodality approach.
Richard?
In short, these cases are very common, of course, and no general principle can be stated. They have to each one be considered individually on their features, the stage or the grade of the tumor with the original biopsy features, and most important of all, has that patient been on any treatment whatsoever, including somatostatin analog treatment, which does have an inhibitory effect on tumor growth. Some patients are best served just by that treatment. But what is not the best is to do nothing. You have to, I feel, be proactive to some degree. This question should be revisited this afternoon after Dr. Wolin, oncologist, is going to give his talk, and we'll touch on this subject.